If you remember, last week we have done, Mr. Terry has discussed regarding the pain management, part 1 and part 2, and we have seen the discussions which was done, case presentation which was done, presented by Madam Anita Bujal, and today she will continue a bit of what discussion we had during the previous session. So today's session is on the basics of communications. So after that, we will have again the case presentation by Ms. Kritika Dula, and then a discussion part, and then the vote of thanks. So once again, I welcome everyone to this third session. So over to the expert for the next session, that is the basics of communication.
Good afternoon all. Happy to see you again. As ma'am said, today we are going to learn about communication part, basics of communication and communicating bad news and the collusion. This session will be taken by one of our eminent faculty, Ms.Rajika kurup. She has done her MSc psychology, and after that she completed her PG diploma in geriatric counseling, and also PG diploma in yoga therapy also. She is working with this as a psychologist for about 2 years. She is a well-versed person in this field because we have a children's palliative care unit and we have inpatient unit. So she is one of the good counselor. She is a apt person in this field for teaching, communicating bad news, communication, basics of communication, and that collusion. Welcome and over to you, ma'am.
Thank you so much, ma'am. Hi, good afternoon all. So I'll just try and share the screen from my end. Is it visible?
Yes, madam.
Okay, right.
Ma'am, sorry,
yes.
ma'am. Can you please keep it in a slideshow mode?
Yeah, sure. Yes. So as both of them have already put, I'm going to take basics of communication as well as breaking bad news. We don't use the term breaking bad news now. We use the term communicating bad news. So because breaking bad news itself is something very traumatizing to hear. So we use the term communicating bad news. So we'll be taking communication, basics of communication, as well as communicating bad news. How to go about communicating a bad news. I would like the session to be as interactive as possible. And if at all there is any doubts or queries or any your clinical experiences or where you would like to share where you were stuck while having a communicating bad news, and maybe just feel free to converse, feel free to interact. If it's difficult for you to unmute and speak, maybe you can use the chat box as well. Okay, right? So we'll start with some of the basics of communication. So it said 60 to 70% of medical errors occurs as a result of poor communication. Most of the time, even when doctors or nurses communicate properly, what the patient had comprehended or what the patient had understood from their part might be completely different from what we are saying. So there itself, there is a gap. So we need to make sure that what we are communicating is being understood by the patient. Whatever we are saying, whatever we are communicating, most of the time patients might know that they have cancer, but they don't know at what stage they are, whether the treatment, if there is any curative aspects possible. So they don't have any idea of what and how it is going to progress and all. So most of the errors happens because of poor communication. So that's why this topic is included in your syllabus. And I guess there might have been places where you yourself would have come to a stop, or you felt okay, I don't know how to communicate. Okay, this patient is in stage 4, or the patient's condition is deteriorating. Her days are counting, but I don't know how to communicate the message to the caregiver. So we don't know how to communicate. So there might have been personal experiences also. So in order to get an idea of how to go about this, we have put this in the syllabus. And I guess through you, through the faculties, I hope the team, the session, the participants are faculties at different departments and at different hospitals and colleges and all. So through you, this has to reach our students. That's the whole point, right? So these errors, at least 60 to 70% of the errors which has been which is resulting as a condition of poor communication could be completely prevented. Right. So next, coming to active listening. What is active listening? I'm going to ask questions here and there, and see, consider it as a very free session where you can, make mistakes, tell, whatever is coming to your mind. I would like to make it as what interactive as possible. So, what is active listening? Okay, what is hearing? What is the difference between hearing and active listening? You can use a chat box as well, okay? It's not necessary that you have to unmute yourself and say. You can use a chat box as well. What is listening? I think I have about 38 participants, no, including myself, right? So I think I have about 35 participants in this session, and maybe some of them are just hearing. Some of the participants are actively listening to what I'm saying. So what is this difference? Okay, I'll myself put, I guess nobody wants to share their thoughts. Right, so actively listening is a very crucial component of communication, okay? So either you can passively just hear what I'm saying, okay? I mean, I'm physically present there, but I'm not actually listening to what the other person is saying. That's called as hearing, okay? So the person is there physically, but not mentally or cognitively. So in active listening, what we do is that we actively process what is being said to us. For example, I'm speaking about communication, communicating bad news, basics of communication. So only if we listen to what is being said to and actively process, comprehend, try to digest the idea, the whole essence of what is being said, that is called as active listening. Okay, and active listening is very important aspect of a successful communication. So I'm dividing basics of communication into two parts. The first part, we'll be dealing with some of the positive body language for active listening and some helpful verbal do's and don'ts in active listening, what you should be saying and what you shouldn't be saying while interacting with patients or caregivers. So we'll be covering the portions in two aspects. So you can see a baby's picture over here. So what do you feel after seeing this baby's picture? Please use a chat box. What does the baby's face give off? Any messages? Is it conveying something? Can you comprehend something from baby's face? Is she okay? Is she happy? That's a very simple question that I have put for Gladys. Thank you, Gladys, so much for the response. No, I don't care. Thank you, Santhya. I don't care kind of attitude, right? I don't know what's happening around. I don't care. Anything else we can make of from the baby's face? Baby is not happy. Thank you, Anita. The baby looks already, maybe she's 3.5 years of age, probably, right? She looks fed up with life, right? Already fed up with life at 3 years of age, right? Not interested. Thank you, Madonna. Thank you so much. Thank you, Trisha. Something disturbing. She looks fed up. I'm done with it. Yeah, exactly. I'm fed up. I'm done with life itself. See, the baby is not even saying anything. The baby is not using any verbal cues or anything else, verbally communicating anything. But we can make a lot of information from just by looking at the baby's face, right? As the poster says, I can be held responsible for what my face does when I talk, right? So most of the time, communication, a large chunk of communication is being taken up by the non-verbal part. So according to Albert Mehrabian's model, elements of personal communication, the verb, the baby is frustrated. Thank you, Shalini, so much. According to Albert Mehrabian's model, only 7% of the whole communication that we do is being taken up by spoken words. So whatever we are verbally articulating is being taken up only by 7% of the whole communication. At the same time, 38% is being taken up by the tone and intonation of the voice. And 55% of the communication is done by the body language. For example, I'm speaking to you, right? I'm communicating, I'm trying to take a class. If what happens if I'm going to take the whole class in the same tone throughout for 1.5 hours? Okay, I'm going to take the session for basics of communication, and the session is being, see, if I continue to take sessions like that, nobody is going to be interested in what I'm going to say, right? So I have to use the intonation, I have to use the voice, the tone. Okay, this part is very important in your syllabus, this part is important for your exam. So if I stress somewhere, you know that, okay, this is important. So these things play a very major role in communication, as well as my body language. If I'm sitting in a very lethargic body positioning, in a very lethargic way, in a very lazy way, you won't feel like listening to what I'm saying, or you won't comprehend most of the things that I'm saying, right? So 55% of the whole communication, 55% is being taken up by body language, and 38% is being taken up by the voice and tone. Only 7% of the whole communication is taken by what is being spoken or verbally articulated, right? So that's why we learn how to keep ourselves. Maybe most of the things that is written over here, you might have an idea, but I might just stress over it, or it would be more like a refreshing class for you, right? So what are some of the positive body language? The first and foremost is eye contact. Just imagine you are sitting, maybe I think you are all faculties and professors and assistant professors, right? So, or maybe you're working at a hospital. So you are standing in an OP. There comes a patient from the door, and you might be referring to some papers or some results that you have in your desk, or you might be scrolling over the phone, and the patient comes over, and we don't even care to look at the person's eyes, right? So, but the very important factor, the first form of communication is done by eye contact. The first form, the very first linking communication is our eye contact. So it is very important. No matter how busy the OPD is, no matter if you're busy at a staff room, just imagine a student or a patient is coming over you. Make sure that you take your eyes off all the things that you're doing and look into the eyes of the patient, right? I'll just stop here. So make sure that you look at the face of you look at the eyes of the whoever is sitting in. It's not necessary that it has to be a patient or a caregiver or a student. Whoever it is, even if you're having a very normal personal conversation, make sure that you look at the eyes of the patient. So even while communicating, while having a conversation, make sure that you're looking at the eyes of the person. And I know that it is difficult to completely throughout look at the eyes of the person, right? The person might feel like, okay, why are you staring at me? Or the person might feel like, and we might also feel tired. Maybe we have seen hundreds of patients already, and this is like 128%, and you feel tired. So it is okay to take the gaze off. But even if you are gazing away, or even if you are looking away, look somewhere else on the face. There is something called as good triangle. Okay, you can look at the cheek side or the chin side or in between the forehead, and also this is a good triangle. You can look somewhere else. If you want to take the contact away from the eyes, maybe you can look somewhere else. Maybe occasionally you can nod your head occasionally. Maybe you can say, go ahead. All these non-verbal things, or these sounds that we make, is a reassurance that you are listening to what the other person is saying, right? So it gives off a very positive attitude about you. Right. So the next thing is, I'll come to the good triangle. See, this is the good triangle, okay? So even if you want to look away from the eyes, maybe you can look somewhere else around here, maybe around the lip area, chin area, or the cheek area. So it is very important to have a proper eye contact. When you look, do it slowly. Don't make a very abrupt, very direct, stern kind of look or stare. Look gently, look slowly. Don't look down when you look away. Never look down on a person. Even when you want to look away, make sure that you are looking at some other spot on the face. Break your gaze, like nodding, to make a gesture or a note. Right, so this is a good triangle. And the next aspect is smile. So practice having a professional smile. You don't have to laugh. Also, the scenario or the situation is also very important. You cannot smile when a patient is crying or anything like that. But whenever you're meeting someone new, make sure that you greet them, you make proper eye contact, you greet them and you smile. The thing is, even if you are wearing a mask or it is okay, because smile can be seen in your eyes and can be heard in your voice, right? Even if you are wearing a mask, make sure that you smile so that the other person will feel welcome. They will actually feel like opening up to you. And the tone of your voice, the way you are communicating with the other person, the tone that you use is also very important, right? They are going to remember whether you were very rude to that person or you were very cranky to that person. The thing is that the thing to do with tone of the voice is that when you smile, automatically your sound is going to sound very pleasant. Your tone is going to be very pleasant, right? Just imagine I'm having a very bad day. I'm having a very cranky face. I'm showing aggression on my face. Okay. So the tone is obviously going to be very rude, right? Right. Okay. I'm having a cranky face. My tone is also going to be very cranky. At the same time, if I'm smiling, obviously my tone is going to be very pleasant and kind. So the way you communicate has to be very soft, very kind, and it has to be soft. They have to feel that warmth in your voice. Okay, though the smiling itself will make pave way to how you are going to sound. Okay, if I'm smiling and speaking, obviously the tone of my voice is going to be pleasant. It's not going to be cranky. Right. The next is body positioning. This is like very important aspect. What we usually see around in our hospital is that the doctor might, if we are going for rounds in ward and all, the doctor might be standing. Okay. Can you pick out a few differences between the first picture and the second picture? That is the left picture as well as the right picture. Is there any difference? Which is better? Any inputs? Any inputs? Okay. Just let me know where the second picture is better. Thank you so much, Gladys, and you're very right. The second picture is much more second and third good position. Thank you, Shirley, ma'am. Thank you. Anyone else would like to say something? The thing is, in the first picture, as you can see, the patient is straining his neck area and the spine area, right? The patient has to bend forward and speak, and the patient is not resting completely, or the patient is not relaxed there. The patient is showing, thank you, Nita. The patient is showing a strained position, okay? The doctor is standing beside, and you can see that the eye leveling is not equal. Okay, the patient has to look up, and here it gives off the idea that the doctor has some more power than the patient. Okay, the doctor is something of more authoritative figure here, right? And the patient is bending forward. So the right way to communicate is pull a chair, sit beside the patient so that the eye level and the body level is equal, so that the patient doesn't have to strain themselves. Okay, so the best way is to sit beside the patient. If there is space constrictions, I do understand it may not be possible to carry chairs everywhere or to carry chairs into ward and all. There may not be much space. Even if you are standing, make sure that you stand at the foot end of the hospital bed, right? even if you're standing and taking or talking to communicating with the patient, make sure that you are standing at the foot end of the patient. So what happens when you're standing at the foot end? The patient can relax, right? The patient can go back, can relax his neck and lie down. And then the eye leveling is also going to be equal when you're standing at the foot end. The patient does not have to strain his spine or anything like that. Okay. So even if you're standing and speaking or standing and conversing, communicating, make sure that you're standing at the foot end. The best way is to sit beside the patient and speak so that the eye contact is similar, the eye level is similar, the body level is similar, and you are at equal. And here the patient satisfaction is going to be much more, right? And when we are talking to pediatric patients, when you're talking to children, what we usually see is that we bend down and speak, right? We bend down to the children's level and speak. But the best way is to bend at the knee level. Again, we are coming to a level, the body level is similar to what the child is, right? So the eye contact is okay. The body level is also similar. So the bending down, when you're talking to a child or a pediatric patient, make sure that either you're sitting beside the child or if you're standing, bend down at the knees. I don't know to what extent this might be possible or what extent this idea might be able to, you can comprehend it, but this is the best way to communicate, right? And next is body posture. Obviously, the first picture gives of a very wrong idea, right? The patient won't even come for a second appointment if you're going to sit like that. So you need to show that, sorry. So you need to show that you are interested in what you're saying, okay? So to show that you are interested in what you're talking to or what you're listening to, make sure that you bend forward, right? Bending forward gives off a very positive message about yourself, right? So bending forward is also very important. For example, I'll stop here for a second, right? So if I'm talking to a person, I cannot just relax back, sit back, show her that I'm very, I'm relaxed, I'm looking at a phone, I'm reading, I'm reading something. I'm reading a book or I'm taking note of something and I'm scrolling through the phone or something like that. While I'm talking to a patient, I'll make sure that I bend forward a little. Okay, I come forward in a way that it gives off the idea that I'm listening to what the other person is saying. I'm interested in what you have to say. So always bend forward. At least slightly make sure that you bend forward. Right. 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 The next. Right. Leaning forward. There is also something called as mirroring the person who is in front of you. Okay. If the patient or the caregiver, whoever is sitting in front of you, if they are also bending forward, you can bend forward. If they are taking a step back, you can also make a step back. Okay. This makes you more likable to the other person. So leaning forward is very important, but there is also something called as mirroring the body posture of the person who is sitting in front of you. Mirroring the body postures of whoever is sitting in front of you. Right. The next part is respecting body space. Here you have to understand that, okay, I have a very when we talk about body space, the body space is usually divided into 4 areas. Okay, I have my intimate space. Okay, my intimate space is mostly taken by the only people who have access to the intimate space is either my spouse or my parents, maybe to an extent my siblings. Okay, this is my intimate space. I'm not going to allow anyone else into my intimate space. And then we have personal space where a little more of our close friends can come inside, or a few other close friends, family, or other members of the family or relative, whoever you're close with. Okay. And then we have our social space where it is being taken up by colleagues. Maybe I'm in a working space. Maybe I'm working. I'm at this hall. I'm working at Pallium. So Pallium is a space where I would say it's a social space. I have other colleagues with me, and the faculties with me, and also That's called as a social space. And then we have public space. For example, I'm standing at a bus stand or a railway station. Then it is called as a public space where the strangers are also present. Okay. So we have intimate space, we have personal space, we have social space, and then we have public space. As professionals of medical field, as healthcare professional, there might be times when you intervene, when you intrude into other person's intimate space. For example, if I'm a nurse or a doctor, okay, this patient requires a catheter change or RT tube change. Okay, Rice tube change is required, RT change is required. So what we generally do is that the patient is a stroke patient, the patient is a severe patient, the patient cannot verbally say anything. The patient is bedbound. What we usually do is that we go there. Okay, we remove the catheter, we apply the medicines, we insert the new catheter, we do all this and come back. Is it the right way to do? No, because we are intruding into their intimate space. See, there is implied consent. Obviously, catheter has to be changed, and we are going there to change the catheter. The patient might also be aware. The caregiver might also be aware that we are there for to do a catheter. So they know that implied consent is there, but it is because of the patient's condition that he has to insert a catheter, right? If he was in a better position or in a better health condition, no one was allowed into that intimate space other than his spouse or whoever is very close to him, right? So whenever we are intruding into other person's intimate space, make sure that you take their consent. Okay, even if the patient cannot verbally speak anything, even if the person cannot verbally articulate, or even if the patient is in coma, or we don't know whether, even if you're saying, we might say that okay, the patient cannot comprehend anything, even then make sure that you take consent. Okay, just inform that, see, I know it is going to be a lot of, I know it's going to be a little discomfort for you, bring a little bit of discomfort for you, but I'm going to remove the catheter. Either whether he is listening or comprehending or whether he can reply back is of none of our concern. Okay, just inform him and remove. It's also something called as we are giving dignity to that person. Okay, we are taking consent. So we remove the catheter, and even before inserting a new catheter, we inform the patient, see, Acha, I'm going to do this, I'm going to insert this catheter. I know that it's going to be a bit discomfort for you, it's going to be painful. So I'm going to insert, right? So whenever we are invading their personal space, their intimate space, make sure that you take consent. I don't know to what extent this might be possible in a very busy OPD, but wherever it is possible, make sure that you take consent. See, we won't feel comfortable if someone is coming over and intruding over our intimate space, right? Because they cannot verbally say anything. They are just lying there and simply getting through all this, right? So take consent, right? So what is the difference between the first picture and the second picture? Is the patient comfortable in the first picture? Is the patient comfortable? In which picture is the patient more comfortable? See, what does the first picture, first patient's facial expressions gives, or what message do we get from the first patient?
He is perplexed. He doesn't know. Maybe he is not knowing about what they are going to do. Second picture is the person is sitting with the patient and talking. So that will definitely win the confidence of the patient. The provider, healthcare provider, will win the confidence.
Thank you so much, ma'am. Thank you so much, Shirley, ma'am. And I have a few responses in our chat box as well. Second one is more comfortable in a more comfortable posture. Thank you, Professor Reshma, ma'am. Kritika, second picture, Kritika ma'am has said that the patient looks more comfortable. Exactly. Thank you so much. Anita ma'am, comfortable in the second picture. Thank you so much. The thing is, in the first picture, as we can see, the patient seems scared of, right? the patient is going a bit back. The patient feels scared, threatened. Maybe the patient is not comfortable. We can see that the doctor physician is invading the personal space, and he's taking a step back. And in the second picture, the body level is correct. The body level is correct, and the eye contact level is correct, right? There is mutual respect, and the patient is more comfortable there. So whenever you're talking to a patient, make sure that you sit beside. If it's not possible, at least maybe you can make sure that you have adequate space between yourself, the eye contact, everything is paid, and you give up a very comfortable posture for the other person, right? Right. The last aspect of body language is touch. Touch is very important. Touch is therapeutic. I don't know how many of you have felt it. A patient who is in a lot of distress, uh, see, if when I do counseling sessions in IP and OPDs and all, there might be a patient who is about to cry. Okay, the patient's eyes, they won't cry. They will hold back all those tears and all. They don't want to break down in front of me. But just imagine at that point, if I'm just holding their hand, they start crying like anything. They just went out like anything. That's the magical power of touch. That's the therapeutical power of touch. I know after COVID and lockdown and all those contagious diseases and all, we fear touching our patients, and all. It is okay to sanitize your hands before and after, or even if you use hand wash and all. But wherever necessary, make sure that you use touch. It could be a pat. Do consider your scenario situation. If it's opposite gender and all, if only if the other person is comfortable, you can go ahead with touch. Okay, you can hold their hand, pat on their back, and touch will give a lot of relief. They feel relief. It's magical, to be very honest, right? So include touch also while you're communicating. So these are the 9 aspects. I think almost 9 aspects are right of communication. So right, any doubt in this area? We have covered just 7 aspects, right? Positive, some of the positive body language. Eye contact is very important. Facial expression, how you carry yourself, the tone of voice, body position, body posture, body space, and touch. So these are some of the positive body language. Right. Next, we move on to some of the verbal do's and don'ts. What we have to say, what we should be saying, and what we shouldn't be saying. And the first one is obviously never ever ask leading questions. So there are leading questions or closed questions, and there are open questions. Never ask leading questions. Leading questions means the answer is already there in the question. For example, there was this patient who was there for consultation yesterday, and he said he had headache, and you prescribed some medicines for headache, right? So the next day you're asking, see, your headache is better, right? The headache has been better, right? Isn't it? Right? All these gives off the idea that even if the patient's headache has not come down, has not reduced, the patient might feel this urge to say yes, right? Because the patient will feel, okay, the doctor expects me to say that the headache has reduced. So I'll say, okay, it has reduced, right? For example provided in the slide is your breathlessness is better now, isn't it? See, we are already implying the answer, isn't it? It's better, right? We should never imply, or we should never say, ask leading questions. Always ask open-ended. See, how are you feeling today? You had a headache yesterday, right? So how is it now? How are you today? How are you today? It's more like an open-ended question, and the patient will start elaborating his or her condition, right? So always ask open-ended questions. Never minimize, never compare patients' problems. For example, see, there you might be working as in an oncology department. You might be working with patients with AIDS or patients with stage 4 of cancer, very progressive cancers, and you might have seen a lot of pain. And there is this patient who has come to you with a toothache. Okay, can we say that after all, this is just a toothache, right? Why are you making such a mess of this? Why are you making a big a big mess of the toothache. You know, I have seen patients with cancer. I have seen so much pain in my life, and you're crying over a toothache. Should we be saying like that? Never. See, for the person who has come to you with a toothache, the toothache is his biggest problem, right? So never ever, it's just a very broad example that I have given. Okay. Never compare, never minimize. You shouldn't be, okay, there is this patient with cancer, the stage 2 cancer, and suddenly you feel like, okay, see, I had my aunt who had similar cancer, and you know, I somehow faced it with much courage and all. You know, you should be more courageous while facing it. Never compare. See, you, if there are 7 billion people in this world, all these 7 billion people are going to take things differently. Okay, in 7 different billion ways they are going to take, right? So never ever compare, never ever minimize what you are going through. It is very important that you don't minimize or compare whatever we are, when we are speaking. Never compare. Oh, don't say that, okay, I had this patient who had neuroendocrine or pancreatic cancer and she had so much pain and this is just a simple thing and you're so crying so much. Never compare. See, for that person, whatever he or she is feeling is big thing. Okay. So acknowledge and normalize patient's emotional experience. See, anybody in your position is going to feel the same. You know, the pain is so much. I completely resonate with what you're saying. I understand what you're saying, right? I do understand what you're going through. Always not acknowledge their pain. Never just minimize suddenly. Don't ever give false hope. Don't worry, we are with you. You know, it's just a simple thing. My hospital has all the equipments to treat this. We can completely treat you. Never ever give false hope. Whatever you're saying has to be truth, has to be correct. And how to say the truth, factual things, is that's what we are covering in the second session, right? So whatever you're saying has to be, whatever you're giving should be a realistic hope and should be truthful. Your disease may be progressive. Let me see what can be done for it. I will explain what are the curative aspects possible in our hospital. Never say that I can completely cure off your disease, or don't give false hope. Don't give hope to a patient who is paraplegic and who is wheelchair bound. We cannot go and say that, you know, let's see, let's do physiotherapy for a year or so and maybe you'll start walking again. We cannot say that, right? Never ever give false hope. At the same time, you might be asking, okay, should we leave him just like that? You know, the person might leave in hope and all. See, you might have all these doubts and all. See, whatever you're saying should be truthful. That's the most important thing. And if you're not quite sure of what is going to happen, you should explain that. See, we don't know at this point. We feel like you might have to take exercises and all. How it can turn up is that something that we have to wait and see. Even if you're not sure of what the condition is, make sure that you communicate the same to the patient. Never give false hope. Right? Right. Never assume. How use your breathlessness? Never assume the patient's condition, whatever it is. Ask open-ended questions and know what the patient's condition is. Right? So empathy as an experience depends on how we behave with our patients and their family. Patients and the caregivers or whoever it is, they are going to remember how you made them feel and felt. They are not going to remember anything else. I still have a patient who still reports, I think it's been about 3 years. She still says that, okay, this doctor in this government medical college, you know, spoke to me very rudely that day and I hate her. I still have that patient who says this. So they are going to remember how you made them feel. That's mostly what they remember. Talk less, listen more, practice positive body language, and remember the verbal do's and don'ts. With that, we come to the end of the first session, and I'm okay to take a few questions, or else we'll move on to the second session and we'll take the questions together. Is that okay? We have like most probably we might have to any doubts still here, or else I'll wait to explain, or else you can just put the questions in the chat box. Okay, I'll address it after the completion of the second session as well, right? Shall we move on with the second session, that is communicating bad news and pollution? A few replies in the chat box would be a great non-verbal communication that you can do. Thank you. Yeah, thank you, Shirley ma'am. right? So this is a very important topic. Thank you, Priyanka. This is even if you are aware of the curative aspects, whatever it is, this is an area where most of the time we come to a standstill. We don't know how to go about it. We don't know how to communicate this news to the caregivers. We don't know how to communicate things to maybe to a pediatric patient, or maybe a child of a mother who is whose days are counting, right? So this is like very important, how to communicate bad news and pollution. So why is this being included in the syllabus? This means why we communicate bad news. Why is it that it is important? Enhance the therapeutic nature of the medical encounter, reduce uncertainty, and improve outcomes of care. Most of the time, the patient may not be aware at which stage of cancer they are, if there is any curative aspects possible. The doctor here said something, the doctor there said something else, the doctor here said it is curable, the doctor there said that your days are counting. There might be a lot of ambiguity for the patient. So in order to reduce the ambiguity, reduce the uncertainty, and we had a patient who completely said that, okay, I don't want to take any treatment for cancer because my mother passed away due to cancer and she had already taken treatment. So people have all these misleading ideas. They might Google things up, and they might be the Google and the Wikipedia might say something else, and they might have a lot of confusions, a lot of dilemma. To clear those things, communication is very important, right? To improve patient satisfaction, to prevent inappropriate hope and guilt. Most of the time they feel like, okay, I might get up and run. Maybe the patient is a paraplegic patient. The patient might be for lifelong. The patient might be wheelchair bound. The patient will feel like, okay, the doctor there said that, okay, maybe after a year or so, my condition is going to be cured. So all these improper, to prevent inappropriate hope and guilt also, this is very important. To prevent a conspiracy of silence. What is conspiracy of silence? Have you heard of this term before? This is like very important, and I'm going to repeat this again, I think in pollution part. Conspiracy of silence is when everybody knows what is going to happen, okay? Everybody knows what is going to, but nobody is ready to talk out aloud about the condition. For example, the patient is aware that the patient's days are counting. The husband is aware, the patient is a wife, okay, the husband is a caregiver. The husband is aware that his wife's days are counting, but the husband is not willing to talk about this to the patient or the wife, and the wife is not in a position to tell about her condition to her husband. What if he might break down? The husband might feel like, okay, the wife might break down. She won't be able to bear the information, right? So this is called as conspiracy of silence. Everybody in the room knows what is going to happen, but nobody is ready to come out and say it loud. And everybody suffers alone. The patient here suffers alone. The caregiver also. I'm just taking a moment for chat box. Can we give time? For example, patient has only 6 months time to survive. I'll come to that, Anita. I'll immediately come to that immediately after this finishing the session. Okay, thank you so much for putting up that question. Thank you. I would highly appreciate more such questions, so that this question there might be people, other people also who might have similar doubts, and also please use the chat box. Okay, so conspiracy of silence. Everybody knows what is going to happen, but nobody is ready to come out and say, and everybody suffers alone. The wife is also suffering alone. The husband is also suffering alone. But if the conspiracy of silence can be prevented, they are together in this, right? They fight whatever is going to happen together. So to prevent conspiracy of silence also, this is important. So if communication is not done properly, it can lead to a range of negative emotions like shock, disbelief, numbness, etc. I was mentioning this patient, right, who hates this doctor in the government medical college. So suddenly it was said to her face that her child, who is almost 1 year old, she suddenly said that this child won't go beyond 1.5. Your child is going to die. And the way the doctor said, she still remembers it. It was very harsh, very rude, and she still hates. The baby did pass away the day the baby did die, but she still hates her for informing her in a very rude, rush manner. The shock and the disbelief that the mother had, she still carries that baggage, right? So if not done properly, it is going to always remain with the patient. If done well, we can lead to a stronger and trusting relationship that can help in better patient care. There are a few role plays that I do usually when we are doing it in on-site. So, example where doctor, I don't feel too good, and the doctor immediately said that you might not have followed what I have instructed you to. Maybe that's why you are not feeling good. You may not have taken the medications. That's why you're not feeling good, right? Immediately, what would we say? See, the patient has come over to the doctor with the hope that the doctor is going to help me in some way. Immediately, the doctor is saying that, dismissing of the patient by saying that you have not followed my instructions. The patient won't feel like talking to you again, or the patient won't feel like opening up to you again, right? See, instead of that, I can see that you are not well enough. I can see that. Tell me what is troubling you. What is that is really troubling you? Again, that is an open-ended question. It allows more venting out. This is another role play. Here, the patient is saying that the patient is not able to sleep at night. Immediately, the doctor is saying, you must be sleeping during the daytime. That's why you're not feeling, that's why you're not able to sleep at night. What if it's not sleeping during the day? Immediately, the doctor is saying, okay, take diazepam tabs. You should sleep well. Immediately, we are prescribing some sleeping pills or whatever it is. You're not actually looking into what is troubling the patient, right? So reasons for sleeplessness would be much more. What if the patient has death anxiety? What if the patient has much more than sleeping during the day or taking some sleeping pills? We had a patient who had sleeping trouble, but every time she slept, she felt she won't wake up. And that was the reason she had this sleeplessness. She felt she will die. So the death anxiety, what if something happens to me? What if some emergency comes? So she had this sleeplessness. So the reasons might be much more. So we need to probe. I understand it must be frustrating not being able to sleep. I can just imagine what you're going through. What has been troubling you? Why are you awake? What are you thinking when you're awake? Is there something that is troubling you at night? Is there any thought that is troubling you at night? So in a way, this will allow more conversations. I know we have time constrictions and it may not be possible for the nurses or the physicians who are in busy OPDs and at least be aware that this is how things are to be, and have people in your team so that they can have a conversation, right? So coming to CBN, that is communicating bad news or breaking bad news, any information which adversely and seriously affects individual's view of his or her future is called as communicating bad news. So this piece of information is going to completely change the patient's outlook. Okay. See, whatever we are going to say is not something that is going to be very pleasant. Okay, so we are going to say something that is going to be very unpleasant, right? So whatever information we are saying is not pleasant. So this is going to completely change the patient's outlook, completely change the way he thinks. So that is called as CBN. Communicating bad news. Why should we learn? Can you spot a few differences between the two pictures? The first picture and the second picture.
First picture, it is broken badly. We lost the yoke. The purpose will not be said. Second picture, it is broken carefully done. And of course, we could get a good result out of it, even if we try to cook the egg.
Thank you so much, Shirley ma'am. She has rightly put, see, the first one, it's a very big mess. It has created a big mess. As ma'am has said, the yolk and the yolk, everything is kind of mixed up. The yolk and the white, everything is mixed up. But in the second picture, we can see, it's separate. It's nicely made into two halves and it's not a mess. So similar to breaking an egg, breaking an egg requires certain skill, right? So similar to that, we need certain skills so that you don't make a big mess out of it. So communicating bad news or breaking bad news is similar to breaking eggs. A certain amount of skill is needed, otherwise you're liable to make a huge mess, right? Right. So why is it that it is difficult for us to communicate bad news? So there are difficulties arise in three levels. Difficulties arise in three levels. One could be environmental barriers. You have so much patients in OPDs, you are busy, you don't have enough time, you don't have adequate space, you don't have a space, privacy or anything. These are environmental barriers. You might be walking over the corridor and someone hands off the research and you say that, okay, you have stage 4 cancer. So these are the environmental barriers. From the patient side, even if the patient wants to know the truth, the patient might feel this fear. What if I break down in front of everyone? What if the doctor says that I have only a few days left? Will I be able to bear the information? So the patient will feel, okay, I won't ask regarding this. What if I ask a lot of doubts? What if the doctor stops treating me? So from the patient side, they might have a lot of things. From the physician sides, why do doctors and nurses feel fear of communicating bad news? Especially in India, we fear the doctor or the nurse being blamed, right? I think you might have seen in your own facilities, especially in India, when it comes to Indian society and all, there is this, it's your responsibility, it's the hospital's responsibility. The hospital is to be blamed for the death. There are a lot of blaming things that happen. So the physician will feel, okay, I won't reveal. What if the patient starts crying in front of me? Will I be able to manage that? So again, the physician or the nurse or the doctor will feel, okay, I won't communicate. They fear managing emotions. They fear getting blamed. They don't want to be the carriers of bad message. See, I don't want to be the person who is going to say this bad message to the family. We all have these thoughts, right? So these are the barriers for communicating bad news. Environmental barriers are there. From the patient side, also some of the barriers are there. From physician side, for example, doctors, and from nurses side, there are certain barriers, right? So it is very important to maintain trust, to prevent inappropriate hope and guilt, to allow appropriate adjustments and prevent conspiracy of silence. Now we are getting to the exact point how to communicate bad news, right? So it usually takes up 5 to 6 steps. Right? 6 steps. We have six steps. It's called as Spikes protocol. I will come to spikes after explaining each stage. So the first stage is getting started. Here, what we do is that even before communicating, we prepare what we are going to say. You plan what you will say. You plan the questions that you are going to ask. Create a conducive environment. Create an environment where you have adequate space, time, and all. Allowed adequate time, and it's not very noisy and all. Determine whom to involve. Should I involve the patient? Should I involve the husband? Should I involve any other siblings or the family members? So who am I going to communicate bad news to, right? So who am I going to involve? These are decided in the first step, that is getting started. We plan what we are going to say. So we set up the area for communicating. The next stage is we assess how much the patient already knows about his or condition, right? Establish what the patient already knows. So obviously the question will be how it all started. How did it start? So the patient will start, I had a slight back pain with which I went to see this doctor, and the doctor there prescribed vitamin D tablets. And even after taking vitamin D tablets and other painkillers, the pain still did not reduce. And he advised a biopsy or whatever it is. The patient will start narrating the whole story, right? So that's the way it has to be. And assess how much the patient knows about his condition. Okay, does the patient know about the biopsy result? Does the patient know any much further about? So assess the insight of the patient. How much the patient already knew. The patient's perception should be assessed. Assess ability to comprehend new news. Give them the option. See, I know you know so many things. I would like to talk about the same. Will that be okay? Shall I talk about the same? I would like to add further to this information. Will that be okay? Is this the right time? Right? Next is how much the patient wants to know. Here, we are about to communicate bad news. Okay, so the first 2 steps has been done. In the third step, we'll make sure that we take consent from the caregiver or the patient. Here, we'll say that, see, whatever I'm going to say is not something that is pleasant or is not something very favorable in your part. This is called as warning shot. Do you still want to know? We already implied that whatever we are going to say is not something that is a good news. It's not something good. Whatever I'm going to say is bad. See, what I'm going to say is not very pleasant. Would you still like to know? This is called as warning shot. We implied that whatever we are going to say is bad, is not very pleasant. Would you still like to know? Only after taking the consent, we move about with the information, right? So we move about the information. So we give the warning shot, we take consent, and then we move. In stage 4 is where the actual sharing of information happens. We are gentle, we are very slow, we clearly mention whatever is the truth. We check whether the patient has understood. We say, we stop, we give space for the patient to express the emotions. The patient might cry, the patient might be angry, the patient might leave you and walk away. There is a lot of emotions that is going to be involved, right? We give space for that. We let them cry. We take it very slowly and we never minimize the severity. We won't say that, okay, see, this is just, after taking out 1 or 2K chemotherapy, after 12 cycles of chemotherapy, you should be fine. There is a chance that, we don't minimize the severity. Whatever is the actual fact, you should convey that, okay? Give time. I know it is a time-consuming process, and I know in busy OPDs, it may not be possible, but this is the right way, right? Respond to feeling. A lot of emotions are involved. Affective responses, emotional responses, cognitive responses. The patient might feel like, oh, I don't know how to go about it. I don't know if I have to take treatment. There might be a lot of doubts. There might be a basic psychophysiologic responses. The patient might start shivering, crying, sweating, and all. Give time for them to react. Listen. A lot of non-verbal communication. Pat over their head, hold their hands. A lot of non-verbal communication has to be done. And the final step is planning and following up. Plan for the next step. What can be done? What are the treatments available in your hospital? What can be done for the patient? Discuss the potential sources of support. Give contact information. So this is called as Spikes protocol. The first is S. S for setting up the area for communicating bad news. Second is P. P for perception, understanding what the patient already knows about his or her condition, the patient's perception. I is invitation, where we invite the patient. We give a warning shot and we take consent. We invite the patient. Only after taking the consent, we will be breaking the bad news, right? And fourth step is knowledge, sharing actual information. The fifth one is emotions. They cry. We give time for them to emotionally react. And the last one is strategy and summary. We plan what we are going to do, right? This is called as the Spikes protocol, and this is what we use for communicating bad news. Okay, I'll just add a few information here. Once we know the patient's condition is very progressive and the patient's days are counting, we usually communicate bad news to the caregivers first, especially in Indian scenario, right? In the Western side, most of the time we communicate directly to the patient. There is no problem in that. But when it comes to Indian scenario, Indian situations, we try to take consent we break the news to the caregivers first and we take their consent before telling the patient. Because if we directly go to the patient and communicate bad news and the patient collapses or faints or, goes into depression or something like that, the caregivers, what happens really, right? The caregiver might even burn the hospital down, right? So in Indian scenario, what we usually do is that we take consent from the caregivers. Right. Thank you, Shirley ma'am, for the doubt. So in Indians, in most of the time, we take consent from the caregivers and we'll communicate bad news to the caregivers first, and then we'll say, is it okay if we convey the same to the patient? And after taking consent, we'll communicate to the patient. Again, with the patient, we take consent. We make sure that we give the warning shot, and if the patient is saying, see, I don't want to know any further. If the patient is saying so, we won't give any further information. We'll stop then and there itself. If the caregivers are saying, please don't communicate this to my amma, my amma is not going to, my amma is anyway okay, please don't communicate. If the caregivers are forcing us not to communicate, we don't communicate. But there are scenarios where the caregivers don't want to communicate, but we had patients who wanted to know her condition. There was this I think there was this male patient here. He wanted to know his condition, but the caregiver, his wife, was in no way allowing us to communicate. So we had to sit multiple sessions with the caregivers, because we have to say to the caregiver, see, he has some idea of his condition and he desires to know about his condition, and it is his right that he gets to know about his condition, and he always asks about his condition, and we might have to say. Again, we come to the caregivers and take their consent and reveal it to the patient, right? We take consent. If the caregivers are not willing, we try to convince the caregivers. We won't force the information. We won't force the information to the patients or the caregivers, right? So this is a spikes protocol. Now, coming to two questions that are there in the chat box. First one was put forth by Anita, ma'am. That can we give time frame example? Patient has only 6 months to live. Do we really know that the patient is going to survive for 6 months? Are we in a position where we can say that the patient is going to live for 6 months? Can we guarantee that? If we can guarantee, I don't know when it comes to life and death, we can guarantee that. Right? We know the condition is progressive. There is bad prognosis, and we see a deterioration is there, but like the patient is responding to medicines. Okay, so we had a patient whose condition, we thought that the condition was EOL, and we communicated bad news to the caregivers, and suddenly the patient started showing better symptom management was given. So I had to sit with the caregivers again, because they hoped that, they felt this, that their amma is going to be better. But I sat with the caregivers and said, see, she had a lot of symptoms. For example, each stage has different symptoms, right? She had constipation, she had a lot of pain. So once we manage these symptoms, the patient will get a bit relief. That does not mean that the progress is better, right? Only symptomatically betterment has happened. Progress is still bad. The prognosis is still bad. But amma is much better. She was able to sleep without pain, and that itself was a big relief to amma. And that was seen on her face. And suddenly the caregivers felt that, the condition is getting better. No. Once we do symptomatic management also, they get better, right? That does not, we cannot guarantee that the patient is going to be there for 6 months. See, life and that is, I don't know to what extent we can guarantee that, right? We can say that, see, amma's condition is so and so. She is in stage 4, her condition, other metastasis is there, other organs are, we cannot be sure how long, but as long as she is here, symptomatic management can be done. Right? If we are giving 6 months guarantee, and if something happens after a month or so, they are going to blame you. What if something suddenly happens and the health deteriorates, right? Especially we have to, it depends upon the patient's conditions, obviously. If it's a patient's condition is like, can be better, can, manage 6 months, I communicate that. Usually I do communicate that, we cannot assure you that she will live like for about 6 months. I cannot assure you that she is going to pass away tomorrow. It can happen. The condition is progressive. I want you to be prepared for it so that it won't be a shock. Next question was put forth by Shirley ma'am. Who is responsible to break bad news in a palliative care team? Or usually the whole team has to be prepared for it. Okay. Usually it's either the doctor or the nurse or the psychologist, or we team up, because when a patient is there, the caregivers might need a clarity on the physical side. What is the pain? At what stage is it? This is more explainable by this information can be given in a better way by a doctor or a nurse, right? But the emotional side, what they are going through, how they are going to, this can be handled by doctors and nurses as well, or the psychologists. So either you can team up or the whole team has to be prepared for it. See, what if the doctor does not have time? What if the nurse does not have time, right? So the whole team has to be prepared. Either you can break it as a team or it can be individually done by a doctor or a nurse or a psychologist. I hope that is clear. If please do ask, even if I'm explaining the answers, and even if you feel like okay, the answer is not sufficient enough, please do let me know, right? If patient don't want to communicate bad news to his or caregivers, what has to be done? We don't communicate. We don't. See, here in palliative care, especially what Pallium India follows, is that the patient's request and the patient wish is of utmost importance than anything else. If the patient is saying, I don't want rights to, we'll remove rights to. If the patient is saying, see, I don't want to stay in a ward, I don't want to stay in a hospital while I'm dying, we'll immediately inform the caregivers that the patient does not want to be in a hospital while she is counting her days, she wants to be at home. We immediately discharge because the patient's wish is of much importance, right? We try to convince the caregivers. If the patient don't want to communicate, but most of the time the caregivers might be aware to an extent about the patient's condition, right? Most of the time. Only if they are not that literate enough, or they have not see the reports, everything, most of the time the caregivers might go through it. They might be coming to us after going to about 2 or 3 doctors, right? They might have an idea. But if the caregivers are saying please don't communicate, she might break down and all, we don't communicate. But if the caregivers are not willing, if it's the vice versa version where the patient wants to know his condition and the caregivers are not allowed, we sit with the caregivers, we tell to the caregivers why it is important that the patient knows about his condition. We make them understand, right? So the patient's wishes is of highest importance, right? So we come to the closing part of communicating bad news. Any doubt, please do use the chat box. You can unmute also. I'm moving on to the last portion of today's session, that is collusion. I won't take much time over here. I know that we have case presentations as well, right? Right. So collusion is withholding information from the significant person. And collusion happens most of the time as an act of love. I don't want to communicate this to my husband. He might break down. What if he cannot manage the information, right? So I'll just withhold the information. This is why usually collusion happens. Collusion can happen withholding information. That's the whole thing from the significant persons. It can happen between a professional, a doctor, of nurse, and the relatives and patients, and relatives and relatives. It can happen due to stigma also. Most of the time it is done with good intentions. See, I don't want to hurt him. I want to protect him from all the pain. So I don't want him to know that his condition is progressive, right? Love and will to protect from emotional, psychological distress. Fear that the patient may, what if I say that she has cancer, and what if she commits suicide? What if she gives up on treatment and also all these thoughts leads to collusion. Believe that the patient may not be able to cope with the truth and about poor prognosis. Other reasons for slide is not moving. Okay, other reasons for collusions, yes, right. Other reasons for collusions could be property issues. A lot of property issues might be there, family disputes might be there, concerns about causing trauma to relatives. If there are old and ailing parents and all, we feel like, okay, we don't reveal the information to the old parents and all. Social stigma, ignorance, and lack of awareness. These are some of the reasons for collusion. But if collusion happens, honest communication is most of the time hampered. Elevated emotional and psychological distress, loss of precious time, anger, guilt, frustration, loss of trust, a lot of unfinished business might be there. I'll explain this with just one case example. Okay, we had a patient. She was 23-year-old female. She had osteosarcoma in pelvis. Hemipelvectomy was done, and it was done on the right leg, but now she was admitted at our IP for pain in left leg. She was not aware. She felt, in the first admission she used to sit on wheelchair, but in the second admission she was not able to even sit because she had that much severe pain in her hip area. Even the slight movements in the leg would cause great deal of pain. And the parents went to RCC, that is Regional Cancer Center of Trivandrum, and from there it was said that the cancer had spread. It is metastasis right now, and the prognosis is very bad. But the mother and the father kept this information from the girl. And after a while, the girl herself felt, the girl started showing a lot of aggression, mainly towards the mother. The girl was like, showing tantrums, was very aggressive and all. And we sat with the parents and we said, you have to communicate this to the child, to the girl. They were not willing. We had like 3 sessions. After 3 sessions, they were like, okay, you can communicate, but we won't be the persons who will be communicating. The team has to take care of it. So the team, we had a conversation with the girl, and we communicated that her condition is so and so. She may not be able to sit because it is metastasis and that it has spread, and that's why the left leg is also pain, aching and all, has pain in the left leg also. You know what happened? She did not talk to her parents for 3 whole days. And during these 3 days, the only person she used to contact was one of the IP in charge doctor and myself. You know what she said? She said, why did my parents keep this information from me? Why did they lie to me that this is going to be better? You know what the parent kept on saying to her? They kept on saying that, once the pain subsides, we can go back to chemotherapy and radiotherapy. That's what the RCC doctor has said. So she was in the idea that this is, but see, when something bad is happening with our body, we have some idea, right? What is going to happen, how it is going to happen and all, right? We do get an idea of, if something bad is happening with my body, I'm well aware of what is happening with my body, right? So she knew that something bad was happening, but people around her kept on saying that you are going to be better. And this somehow created a lot of conflict within her, a lot of frustration, which she used to take upon the mother. And after 3 days, she started talking to her parents. The first thing she also asked was, why did they lie to me? Trust, breaking of trust is also very important here. And after 3 days, her aggression came down like anything. She was much calmer. Because she knew her condition, she knew why she had so much pain and why her left leg was also aching, and the aggression towards mother, everything came down. So this case explains to a great extent the importance of breaking collusion, right? So if there is collusion, we usually say as collusion positive. That is, there is withholding of information is there. And also, in order to avoid these things, we need to make sure that collusion is not there. So what happens? Both parties are grieving, but alone conspiracy of silence is there. Constant stress and burden of hiding for the caregivers is there. Inability to eat, sleep, and communicate properly. Patient also feel out of control and trapped. So acknowledge collusion, explore reason. Why are they withholding information? What are they fearing, right? Explore, talk to them, explore their concerns, and try to manage the collusion, right? Remember value statements by family members. If the family members are saying, okay, I don't want to communicate, don't communicate. We always have to value what the family members, they might say that, I don't want any curative aspects. I want church people to come and do a prayer. I don't want the temple priest. I want the temple priest and come to do a prayer. We do that. We just communicate what can be done from our side, but the decision will always come from the family side, the members. Acknowledge family members' emotion, listen to family members, understand who the patient is as a person and who takes the decision, elicit doubts, questions from the family members. With that, we come to the conclusion of our topic, collusion aspect. So we covered basis of communication. Within that, positive body language and verbal do's and don'ts. After that, we took the session on communicating bad news, and finally we came to collusion. And I'm open to questions if at all there is anything. I'm sorry for taking up so much time. I'll take 2 minutes if at all there is any doubts. Any doubts, anything that you want to share, you can use the chat box. Or you can unmute and talk to me. I hope I have made myself clear of communicating bad news and all. If the doubts are persisting, you can also use the WhatsApp group if you think there is something more that you would like to know and all, right? If there is nothing else, we'll move on with the case presentations. Any doubt?
Thank you, Rajika, for that wonderful presentation. Any doubts? So we have learned many things today, communicating bad news, what are the basic communication skills, that all things we understand, and also collusion. So what I want to highlight here is one important thing we all always keep it in mind. All you have to teach the nursing students where we are using non-verbal languages more. So that is very, very important because we are spending, our nurses are spending more time with the patient, most of the time with the patient. So our non-verbal language sometimes it will be affect the patient emotionally. So that we should avoid. So that thing you have to convey with them and don't give premature reassurance, don't give false hope. These all things is very, very important. So at least to explore, listen their worries. So one of the basic communication skill listening is listening. Listening is one of the most important part here. So you have to tell them if time permits, they definitely they have to go to the patient side and listen their worries. Once they explore their problems, they will get a good mental relief. So that is one important thing you have to convey with your nursing students. Okay, thank you. We can move on to the case presentation.
Arya, I think you can share.
Ma'am, may I share the screen?
Yeah, sure. Please go ahead.
So may I start with the presentation?
Yes, please go ahead, Kritika.
Yeah, good evening all. My name is Kritika Dulal and I am a tutor in Sikkim Manipal College of Nursing. And today I brought a very common case, yet I feel that it requires palliative care. So my patient age is 57 years and female, and she is with diagnosis chronic liver disease with decompensation and portal hypertension, moderate esophageal varices, coagulopathy, dimorphic anemia, and dengue positive. Her comorbidities are she is hypertensive since 6 years and is under medication telmisartan 40 mg OD. Her present issue are she was brought to Central Referral Hospital with the chief complaint of fever and body ache since 7 days, abdominal distension since 7 days, swelling of both the lower extremities 7 days, and generalized itching since 7 days. Next slide.
Please wait for a minute. The slide is not changing. Is the slide visible? Please go ahead, ma'am.
Yeah. May I please have the next slide? Yeah. So history of present illness. Patient was brought to Central Referral Hospital with the chief complaint of abdominal distension, swelling of both the lower limbs, and generalized itching since 1 week. Patient had undergone ultrasonography of abdomen on 6th of June 2024 and was found to be diagnosed with hepatosplenomegaly, which also was suggestive of chronic parenchymal disease for liver, and also was diagnosed with portal hypertension. She was again admitted with the similar complaints in the month of September when she underwent gastrointestinal endoscopy, which showed esophageal varices due to portal hypertension, and ultrasonography of abdomen showed ascites, for which she already underwent therapeutic ascitic fluid tapping. She went for blood transfusion as her CBC and her peripheral blood smear revealed dimorphic anemia. Next slide. Yes. On 25th of November, she was again admitted with the same complaints in the high dependency unit, and she underwent diagnostic evaluation, that is a CBC, urine analysis, ultrasonography abdomen, PT-INR, anti-dengue for dengue, peripheral blood smear, glucose tolerance test, stool examination for occult blood, serum electrolytes, kidney function test, liver function test, serum iron and transferrin. So patient is a chronic alcoholic since last 24 years. She used to take beer around one bottle, that is 650 ml approximately every day. And whiskey she used to drink occasionally, that is 90 to 120 ml if she had taken it. Next slide. So the detailed assessment of the present issues on admission, that is on 25th, she had temperature of 100.3 degree Fahrenheit, pulse 88, respiration 20 breaths per minute, and blood pressure 110 by 80 mm of Hg. Vital signs on examination, that is yesterday, temperature was 97.2 degree Fahrenheit, pulse 82, respiration 18, and blood pressure 120 by 80. Abdominal girth on the day of admission was 94 centimeter, and abdominal girth yesterday after fluid tapping, it was 86 centimeter. Her body weight on admission was 53, but she had gradual weight loss every day around 2 to 3 kgs. So on examination, she had 48 kgs of body weight. So abdominal assessment, inspection showed abdominal girth 86 centimeter, shape was round and no other abnormalities was detected. Auscultation, bowel sounds were heard and no abnormality detected. Palpation, she had mild tenderness over right hypochondriac and umbilical areas. Percussion, it showed shifting dullness because of ascites. So resonating areas were found after changing the position of the patient. Next slide, please. So psychosocial issues, coming to first the occupation of the patient. She is a homemaker and her spouse deceased 7 years ago, and she has number of four children in and out of whom 2 children, they don't stay with her and she has no contact with those two younger children, they stay together. So her issues are financial instability that is related to her health expenses and her home rent. And she's anxious regarding education of her children because one of her younger child, he is just 22 years old and he's still a student, and she's partially dependent upon children for her daily activities. So insight of the patient has complete insight about her illness. She described that I have been told by doctor that I have a failing liver and I will require continuous treatment. I am told that the cause is definitely alcohol. I tried to quit, but I'm stressed and have to look after family. So alcohol helps me cope. Family as in one son and one daughter. Other than that, she's also taking care of one of her niece. And her family, they know that she has liver failure and has to quit alcohol, so she has chances of internal bleeding also. So family have a little low insight. So this is the family tree. All of her family members are deceased, and except for her 4 children, out of which 2 children, they don't stay with her. And the younger child, 22 years old, he goes to the college, and the next child, the daughter, 27 years, she earns for the family. So nursing assessment, her vital signs, temperature, pulse, respiration, blood pressure, SpO2 and pain, they were all in the normal range. Pain according to the numerical rating scale was 4. Patient is conscious and oriented to time, place and person. Skin looked dehydrated and dry. Respiratory system, bilateral air entry is equal. No any abnormality were detected. Cardiovascular system, both S1 and S2 heard, no abnormality detected. Same goes for GI. Upper extremities, no abnormality detected, and she can perform all the range of motion exercises. But for lower extremities, she has non-pitting edema for both the lower extremities. Her capillary refill time is 9 seconds, and her CBC also reveals that she is anemic. Her dependency level is she is partially dependent upon her family members. So her LFT values, I have only mentioned the values that have been increased or decreased. So her albumin was low, globulin increased, albumin-globulin ratio was decreased. SGOT for LFT, all the values, mostly all the values were increased. Serum electrolyte, calcium was decreased, potassium decreased, and creatinine also decreased. CBC, her hemoglobin results reveal 8.9 gram. That's why she had undergone 1 blood transfusion also. And hematocrit was decreased, MCH decreased, neutrophils increased, suggestive of infection. PT-INR and INR PT prothrombin time and INR are increased. Serum iron is decreased, and anti-dengue showed positive results for dengue. So USG abdomen showed coarse hepatic echo texture with irregular margins that thicken gallbladder wall, splenomegaly, and mild ascites. Upper GI endoscopy shows esophageal varices with congestive gastropathy. So her previous medication, she was taking telmisartan 40 mg for hypertension, and currently she is under tablet furosemide 40 mg BT, UDCA 300 mg TDS, tabsalmarin 140 mg BT, tabcarvedilol 3.125 mg BT, capsule isomeprazole proton pump inhibitor 40 mg, injection phytomenadine 2 mg because of our elevated PT-INR results, albumin powder 2 scoops, syrup ambroxol, syrup lactulose, syrup sucralfate, injection ceftriaxone, injection meropenem, injection paracetamol, and tablet folic acid. So the reason why I selected this patient is since chronic liver disease is a chronic condition and it requires regular treatment. So I feel that if a disease requires regular and a long-term treatment, so palliative care should be started in the beginning only. So I chose this patient. Also, she requires education related to how to cope up with her stress and how can she not continue her alcohol and cope her stress. So that is the reason why I chose this patient. So communication issues, patient was very good communicating. She was answering all her questions except for she was a little bit agitated because of hospitalization. Otherwise, she was good at communication. And regarding her alcoholism, she was still denying that she does not want to discontinue. So she's still addicted to it. So the main concerns are financial instability. She mentioned that she has to take care of the family. She is partially dependent upon her family members, and stress-induced alcohol intake, poor prognosis, and family concerns. So summary, a 57-year-old female admitted in CRH with complaints of fever and body ache, abdominal distension, swelling of both the lower extremities and generalized itching since seven days, underwent diagnostic evaluation which ruled out chronic liver disease, portal hypertension, esophageal varices, dimorphic anemia and dengue. She has past medical history of hypertension and she is currently under the treatment for the same. She is also a case of substance abuse, that is alcohol. So the points for discussion I feel are: does the patient actually require palliative care? How can the patient be explained regarding quitting alcohol and coping mechanism? How can her psychosocial issues be addressed? Thank you.
For the wonderful patient story presentation. I hope this presentation is clear to everyone. We can move on to the discussion points. So we would like to hear from you all first. Others, please respond.
Does the patient actually require palliative care? Does the patient require palliative care? Please, the others, please, you can unmute yourself or you can use the chat box as well. Does she require palliative care?
Yes.
Please go ahead, ma'am. Shirley, ma'am, you want to explain? Yes.
Yeah, she requires.
As Kritika has already put forth, this condition is something that the treatment has to go about for a very long term. The treatment will go about, and it's not one thing that she's fighting. Is it the only physical symptoms that she's fighting?
No, she has a lot of psychosocial issues.
Lot of psychosocial, and I don't think she has an idea of how to go about in the future also, because she's still continuing with the alcohol, right? That is the source of her own disease is still persisting there, and she is not ready to do anything regarding the source, right? And this is going to actually add to her condition. This is going to worsen her present condition even further, and she's not willing to quit alcohol. And I don't know to what extent the children are aware of the importance and all. And I think Kritika said that she is very calm and all. Maybe that's because due to she's still consuming alcohol. What if we suddenly stop alcohol? A lot of withdrawal symptoms will start showing up. A lot of irritability will start showing up. A lot of emotional distress she might start showing up, right? So alcohol de-addiction of alcohol is one thing that has to be done. But again, we cannot force things to her. We cannot force her to which is not that severe that we have to force her into a rehabilitation center or anything. We need to have multiple sessions with her where we convey if she is going along with her present routine or daily routine, her condition is going. That communication part has to be dealt with. How this is going to affect her in the future, what her condition is going to be in the future if she continues to be so. This has to be clearly conveyed to her.
Yes, that is
right. Because if she continues to be so, that's the part that we have to do. We have to convey if she is going to continue like this, her condition is going to be so and so. Maybe even other organs might be involved, which is going to be affected, and this is how this is going to be. And if you're okay, like even if after listening to all those things, if she's still willing to go ahead with her, we cannot force her. Obviously, we cannot force her. But the concerned people has to be informed. Her children or whoever is now there with her, they should also be informed or communicated with them also that this is her condition. And whether the person requires palliative care, obviously the person requires palliative care. It's not just due to the physical aspects I'm saying. You have to explore the spiritual side also. Is she a God-fearing person, or does she have hope, or is she completely right now hopeless? Whether she feels okay, there is no use of me living like this. That's why I'm again consuming alcohol. Is this the reason why she is continuing alcohol? The reasons of why she is continuing alcohol has also to be explored in here.
So at the same time, she is worrying about his
Children's education.
We have to identify the cause why she is not willing to stop alcohol. So that we need to look into. Find out time and sit with her and explore her feelings.
A person who is concerned of their children would never want to die of soup. You know, they don't want to worsen their physical conditions, or they don't want to leave this earth very soon. So there is some strong reasons that she's holding on to why she's continuing alcohol. And even if we sit with her and talk to her, maybe you need a rehabilitation and in a de-addiction center or something that might be required. If you're really concerned of the children and all their education and all, that is a very strong, I would say, a spiritual aspect. I would say, the love for the children, that is also a spiritual aspect. We can hold on to that and explain to her, make her aware how this is going to affect her in the future.
So, yeah, and one more thing, she might have heard about withdrawal symptoms. Maybe she afraid about that also. We just sit down and listen her problems first. Then you
Ma'am,
just
Yeah.
so sorry to interrupt, ma'am.
no,
She
no,
please
mentioned
go
that
ahead.
continue.
she also mentioned that loss of her husband. After she lost her husband, she started consuming the alcohol a little bit more in amount as compared to before.
Right.
So I feel that she is still not over
The grief,
that loss
the grief,
of her husband.
yes.
Grieving, she's still in
Yeah.
the stage of grieving.
Yeah, so that grief is not resolved. Okay, as far as what I could make out of the case presentation, she is still grieving, and we suddenly take up habits after losing a person because we become dependent to that. The concerned person is not there. The spouse, the husband passed away. No, she doesn't have any other reason to hold on to, and then that's when we go into drug abuse or a dependence for alcohol and all. That's the only thing that's holding her up, right? And she has not come over the grief of passing away. I don't know if grief and bereavement has been done. Is the session done? No. So the grief is something that is still she's processing. Okay, that could be also one of the factor as we have made it. So anything else, ma'am?
No, we can move on to the next part, next case presentation. Really, this patient need palliative care, and we need to address the psychosocial issues and find out the cause and try to solve the cause. So that's how I think we can manage these patients. Explore their emotions first and identify the cause. And if there is a withdrawal symptom, there is a problem inside her mind there, definitely we have to tell them like we are there with you. So if there is a withdrawal symptoms comes, we will take care of that part. So that kind of things you assurance you can tell her.
Thank you so much, Kritika. That was a wonderful presentation. Thank you. Very nicely,
Thank you,
neatly
ma'am.
put. Thank you.
Thank you.
Okay, Anita ma'am.
Yes, ma'am.
Arya, can you share the screen? Arya, are you there?
There is network issue. I have asked Pooja to share the screen.
Okay.
Yes, ma'am. Just wait, let me find. Just wait.
So sorry for taking so long. I know we are past our session time, but as ma'am has said, ma'am did mention to me that the last case presentation had so much communication part in it. So it is very much relevant to what our session was today, right? So we'll just explain, at least we'll go through the discussion points.
I hope my screen is visible.
Yes, very much visible.
Yes. Please let me know where I have to stop now.
Yeah, right.
This one?
No, we need first part itself.
First part. Which one? This one?
First, go back to the first
Can
slide.
we start with the first slide? Yeah. This will.
Yes, ma'am. Anita, ma'am.
Anita, are there?
Shall I start?
Yes.
Patient is 42 years female, diagnosis CA lungs with T3N2M1C. Comorbidities, no comorbidities were found in the patient like diabetes, hypertension, pulmonary tuberculosis. On 31st January 24, patient came with chief complaint of swelling right side of the neck since 8 months, back pain, cough, shortness of breath, teeth ache for 10 days, and hemoptysis 1 week. Patient started noticing swelling on the right side of the neck in July 2023. Since she had no problem initially, therefore she did not took any medical treatment. After few months, she started having difficulty in swallowing and chewing. Then she went to district hospital and got treated. Since her symptoms started increasing, she was referred to STNM Hospital, Sochagang, East Sikkim for further treatment. At STNM Hospital, CT thorax was done, and the report was seen like intralobular septal thickening, right lung parenchyma, right lower zone, numerous nodules scattered in bilateral lungs, hepatosplenomegaly, and fine needle aspiration cytology was done. It showed metastatic CA adenocarcinoma. And she was treated with 6 cycles of palliative chemotherapy. And the 6th cycle of chemotherapy completed on 30th May 2024. After that, her symptoms were reduced and was feeling better and coming for regular follow-up. Again, on 16th November 2024, she got admitted with complaint of headache and vomiting. So, patient was admitted with complaint of headache and vomiting, and also she had decreased appetite, disturbed in sleeping pattern. Coming to the psychosocial issues, patient is very anxious and worried about her children, future of her family, and patient is very weak and is homebound, and in the hospital she is bedbound. She is not able to meet the friends and other family members. She is also worried about the medical expenses because she has been getting treatment for so long. Insight of the patient and family, patient was told that patient is not told the actual diagnosis, but she has been told there are some small masses in both sides of the lungs, both lungs, and it can be reduced in size once she starts getting the chemotherapy. Whereas family has the total knowledge about the diagnosis of the patient. She has stage 4 cancer of lungs and outcome is very poor. And they were also told if they want to take patient outside, can take outside Sikkim. Since they were economically very weak and they had given the doctor to start the chemotherapy. Family tree, both our grandparents, they are deceased. Her father and mother, they are alive. They don't have any other medical issues. Whereas she is the eldest daughter of the family and she is the one who is having CA, and her habits are, she is not a tobacco smoker or chewer, but she is an alcoholic.
We can skip this, ma'am. Okay.
Assessment part can be.
We can skip. Next. Yeah.
So why did I select is because our faculty development program, it is on palliative care, and I found this to be more suitable for our learning purpose. So I have
selected this. Communication issues here. While communicating with them, patient was not able to answer all the questions. So means she was very weak, fragile, and less energy was there. So whatever information I have taken from, that is from the caregivers. And your main concern is patient has financial constraints, prognosis is very poor, and patient has decreased quality of life, patient has pain, patient has vomiting. So, summary, a 42-year female was admitted in oncology unit of STNM hospital with chief complaint of swelling right side of neck since 8 months, back pain, cough, shortness of breath, teeth ache since 10 days, hemoptysis since 1 week, and past diagnosis was CA lungs with T3 and 2 M1C. She underwent 6 cycles of palliative chemotherapy, started on 8 February 24 and completed on 30 May 24. On 16 November 24, patient was readmitted with complaint of headache and vomiting. MRI brain was done and it showed metastatic brain, and the patient was started with palliative whole brain radiotherapy. So here points for discussion is, does the patient need to know about her diagnosis? If yes, how we can share with the patient? Number 2, how can we address our psychosocial issues? Number 3, how can we improve the quality of the life of the patient? And one more I had told that day because it is not tight here. The fourth one is, since patient's prognosis is very poor, how can we provide end of life care?
Okay, thank you, ma'am, for representing this patient story again. So we can move on to the discussion part.
Does the patient need to know? See, every patient has every right to know about their disease conditions, no matter what. Okay, every person, including myself, ma'am, and every patient has every right to know about their disease condition. But we have to follow the spikes protocol. You cannot just randomly go and say and come back. You know, you are in stage 4, you are going to die, and the census. You cannot do that, right? So obviously, the patient does need to know, but we have to take the consent, right? That's so the whole session of communication, I think the whole session is there in this discussion point, right? So we need to sit with the caregivers. I think the caregiver already knows the prognosis is bad, so there is collusion also, right? The caregivers know that the condition is bad, the prognosis is bad. I think that's what the family members, they already know, but in some way they are not willing to communicate. I don't know if it is collusion or they have not tried to discuss. So explore why they have not revealed to the patient. Give them if they are willing, give warning shot, take consent, and do let the patient know. If she is willing to know about her condition, we have to break, right? Every patient has the right to know about their disease condition. Even if it's my mother, even if it's my father, they all have the right. If there is no, it's my mother, I don't want to make her cry, I don't want to emotionally distress her. There is nothing there. Everybody has the right, but only if they are willing for it, right? So how can we improve the quality of life? Obviously, addressing those issues. There are a lot of financial issues. Their children, she might be having a lot of other issues were also mentioned, right? So when it comes to our session today, this topic is very much needed. I think if the patient, is the patient still there, ma'am? Anita, ma'am?
Yes, ma'am.
Is the patient still in your IP or
No, right now I have not visited, ma'am.
Okay, fine. Okay, no issues. Right. So any other inputs, ma'am?
So as ma'am said, we have to, if she wants to know the diagnosis, you have to tell them, as we are using spikes protocol for communicating bad news. But before that, if there is a collusion there, you have to break that collusion. You have to address the collusions. You have to make them understand that the importance of that knowing the diagnosis. So that is one of the important part here. And another important thing, psychosocial issues. If there is a psychosocial issues there, definitely the physical distress will increase, right? The distress intensity will increase. So we have to address the psychosocial issues also. Always remember the total pain concept: physical, emotional, social, and spiritual pain concept. So we have to address those parts. Okay. And also that end of life care thing, improve the quality of life. Definitely we need to improve the quality of life. How can we improve the quality of life? If we can able to reduce their signs and symptoms, definitely we can able to improve the quality of life.
Also, we can explore whether they have any wishes, any unfinished business that they would like to do. We had patients who said that, they want to visit a temple. There might be little wishes also which can be granted. That is also a part of improving quality of life.
So coming to the end of life care part, definitely we have to make her dying process easier. So that is the aim of that end of life care and palliative care. Okay, so make the dying process easier. So we have a session on that end of life care. That time we will discuss more about that. How can we address each symptoms, that all things we will discuss that time. Definitely we can able to provide a good end of life care.
A lot of dignity, everything is involved during end of life. So that will be covered. So thank you so much. And we are so sorry for taking so much time, extra time also. Okay.
Okay. Shall we wind up? Thank you.
Ma'am, wait. Let me give the feedback.
Yeah.
Wait, ma'am.